Well, hi there. Welcome back. In this video, we're going to talk about remote therapeutic monitoring and billing, the RTM CPT codes, and some of the challenges and unique elements of these new codes for physical therapists specifically. My name is Dr. Andrew Gorecki. I'm the owner of Superior Physical Therapy, a private practice in Northern Michigan, as well as MovementRX, which we help clinics around the country implement and execute remote therapeutic monitoring in their clinics in order to receive the financial benefit of that, as well as the improved patient outcomes. So um, let's talk about first what the codes are and the rules that are associated with those codes, just to kind of cover our bases. So the AMA released these new codes in 2022, so they're relatively new. And these codes are unique and individual, and they have rules associated with them. Hopefully, the software program that you are creating your home exercise program that also allows for remote therapeutic monitoring to occur is tracking these rules and generating these codes for you automatically. That's the benefit of having a software program. So the first CPT code is the 98975, and that is a remote therapeutic monitoring code that is specifically for the initial setup and education of the patient using the software device to access their home exercise programs. The rule on this code is that it can be billed 30 days after the patient has been entered into the software. So there's a 30-day rule. So today's the 30th of April. That means that I'm not able to submit that code for billing until 30 days has passed. And it's a one-time code, so you're not going to bill that more than once. The second code is the CPT code 98977. This is a remote therapeutic monitoring code mainly for the device supply. So recognizing that the patient having access to the software on their phone or their device, there's cost to that software. And so this is a code that can be billed every 30 days, as long as in that 30-day period of time, there has been 16 days of data transmission back and forth between the device that the patient is using and then our software. So that's a 30-day, again, another 30-day timer there. But that's every 30 days, which is great, as long as the patient has access and the system is communicating. Now we get into those were like the technology-based codes. Now we're getting into the codes that are related to the monitoring time. So the actual provider, a licensed either physical therapist or physical therapy assistant doing the monitoring time. Then the first one is CPT code 98980. This is for each 20 minutes. It has to be 20 minutes or more. It can't be 19 minutes. So for every 20 minutes, that first 20 minutes is under this code, as long as it's been done by a qualified professional and there's been one two-way audio communication with the patient and the provider outside of patient care time. Could be on the phone, could be a video conference, could be in person, but it's got to be outside of patient care time. This is a calendar month. So this is what has been generated in the calendar month. So at the end of the month, the code is ready to be submitted. And then the CPT code 98981 is any additional 20 minutes. Right? So same thing, end of the calendar month. So you can see the first two are 30 days. The second two are end of calendar month. So those are kind of the rules that are associated with these codes. And again, your software program should be tracking and generating those codes based on the rules. When the rules are met, the code should be ready to be billed. If the rules aren't met, the code should not be ready to be billed. Okay, so now with the rules understood, it's important to recognize, how do you find out like which insurance companies pay for this service, and then also what do they reimburse? So the first one is Medicare. Medicare reimburses this across the country, and that's great news. And so the first step is you've got to find out what region or what like locale that you are in as it relates to Medicare having a code for you, and you can do that by going to the website that I have posted here. So you got to find out your region, and then you can go to the CMS website, their physician fee schedule lookup, and you can type these CPT codes in for your region, and it will tell you the exact reimbursement rates to expect. from Medicare patients that are receiving remote monitoring services. Now, that's easy. The commercial payers are a little bit more challenging. So we know that we've found policy documents from Blue Cross Blue Shield and United Healthcare are the only two that nationwide say they're paying for this. There are some exceptions. I posted in here a document from the AMA that shows some of the exceptions, the states that they found that commercial payers aren't paying for. But the bottom line is it's challenging, and you highly recommend that you reach out to each one of your commercial payers, ask them for policy documents related to RTM as well as reimbursement amounts for each code before you would consider, submitting, any RTM CPT codes to be paid, because you might get disappointed. Now, the next thing that we want to think about with billing or submitting these codes is how your EMR system allows you to do that. Now, it's important, before maybe we talk about that, let's talk about, like, how are these codes unique? What are like, they have different behaviors. We talked about the rules. Those are kind of unique behaviors. But it's important to recognize, like, the first unique behavior here is that the RTM CPT codes are not considered a visit, right? They're defined as sometimes therapy or ongoing therapy. Think of it, it's accumulating throughout the entire month. And then at the end of the month, those codes are generated. So that means there's no defined date of service, which is very unique, right? Every code we've ever submitted has, like, here's when the patient was with us. I submitted it based on this date of service. Well, that doesn't apply for RTM CPT codes. So that also means if it's not a visit, that there is no SOAP note requirement. There is no copay attached to this. This should not count against your visits for your authorizations or your plan of care visit requirements. So that's important to recognize, that RTM CPT codes are not a visit. However, both Medicare and the EMR systems are still requiring a date of service to be posted in order to submit these claims, even though there is no date of service, right? The date of service technically is an entire month, the previous month. If you have the codes in front of you now, it's last month. So they behave differently in that aspect. So if Medicare requires a date of service and the EMR requires a date of service, you've got to come up with a date of service. But the date of service is kind of arbitrary. So what I do in my own private practice is I create a date of service that is it's the first Saturday following the month's end. And the reason that I pick a Saturday is because Medicare also will deny duplicate claims. So let's say if I submitted last month's RTM CPT codes today, but the patient was also in our office today receiving normal care, one of those two is going to get denied for duplicate submission. So we don't want that. So I pick the first Saturday of each month. The second unique behavior is there's no copay, as I just mentioned, but this is not a visit, so there's no copay. Now, there are EMR systems out there that force you to attach a copay to claim submissions. So that's something to think about. Mine does that. So that's kind of a pain. My biller has to go in and delete the copays for each claim submission at the end of each month, which is really annoying. Again, I mentioned this, but there's no SOAP note requirements. So you might be thinking, well, wait a minute, there has to be some documentation. Well, the documentation that's required actually is at the onset. So the plan of care has to have the frequency, duration, the justification, just like any other code you're going to bill. And then that has to be signed by the physician, right? So that supporting documentation is required. As far as a SOAP note goes, there isn't a SOAP note requirement. Now, you may be required to create a visit in the SOAP note if your EMR requires it to submit the codes, but there is no requirement there. Now, supporting documentation, if you're requested to, like, prove what you did during the times of monitoring, that should be in the software program you're using. That should be downloadable, and of course you can provide that if requested. But again, the SOAP note is not required. Some other things that are unique, the PTA reduction, the 15% reduction. If a PTA is involved, that applies only to the monitoring codes, the 980 and the 981. It does not apply to the first two codes that are technology-based, the 98975 and the 98977. So you have to make sure that if a PTA is involved, you are adding that what's called the CQ modifier to the 980 or the 981, again, through your EMR system, most likely, so that Medicare recognizes there's a 15% reduction and you're being compliant. Another interesting unique behavior is the place of service. So it kind of falls in between. It's not telehealth and it's not in the clinic. It could be in the clinic. In my clinic, we use just normal in-clinic place of service. I have heard of other clinics getting denials from their secondaries stating they require it to be a telehealth place of service. So again, something to consider, or a unique behavior. So kind of back to my comment earlier, my point is, all right, so now we have to take those unique behaviors and figure out how to submit those codes through our EMR system. And that's probably one of the most challenging things in the beginning that takes a lot of time to figure out, right? Every EMR system is different. Some of them have created or adapted to these rules and these behaviors of these codes, and others haven't. Mine, for example, hasn't. So we have to do one of these scenarios. So let's talk about the two most common scenarios. So scenario one is, you've got the end of the month has ended. You have your RTM CPT codes ready to submit. The patient is here today. I'm just going to add those codes onto the daily note. I'm going to do my normal daily note, do my normal CPT codes, and then just add those on there because they're ready to bill. That's one scenario. That works really great for like half the patients. So what I mean by that is, let's say that today was the patient's last day. Now, I have to wait till the month is ended in order to generate the codes that occurred for this month. So when I have those codes ready to be submitted, that patient's not going to have a daily note to submit because they're no longer being seen in the clinic. So it doesn't work for everybody, but it's definitely a scenario. The most common scenario is number two, which is essentially you need to create an RTM visit type, right, in your EMR system. Since there's no SOAP note requirements, you can clear out the SOAP note information and just allow that visit type to submit the codes under that patient's plan of care, or you can add some information in there if you feel like you want to. This is the best case scenario. So if your EMR has a visit type that's already been established, it should not account against your visit alarms. It should not add a copay, right? And so that would be ideal. And it should allow you to just simply put the codes in with no SOAP note information. Again, that really depends on your EMR system. So I would contact them and ask them, do you have any instructions or information for me while I'm setting up this RTM system for our clinic? This is always overwhelming, by the way. It takes a lot of time the first couple of months, but once you establish your system and your routine, it shouldn't be overwhelming, right? It really shouldn't be. It will be systemized. But definitely something you want to think about when you're looking at submitting these codes. Now let's talk about some of the challenges that I've experienced in the last 2 years, as well as what I've experienced with other companies that I help do this across the country. So one of the biggest ones is you've got to recognize that the first two codes have a 30-day time frame. Not only 30 days has to pass before you can generate the code, but you can only submit the code every 30 days. So you got to make sure that let's say if I pick the first Saturday of the month to submit all my claims from last month for RTM, I also have to make sure that I pick the first Saturday of next month, so there's 30 days in between. This gets a little harder in February, right? Especially if it's a leap year. So you just got to make sure you've got 30 days between your submissions. Otherwise, you're going to get denials mainly for the code 98977 because Medicare or the insurance company recognizes there hasn't been 30 days between the two codes, and it's a 30-day code. Another thing to think about is duplicate submission. So again, we mentioned this, but if you have a patient in the office today being seen and you also submit RTM CPT codes in the same day with different submission, like 2 different visits, one's going to get denied because Medicare does not accept duplicate submission dates, which is why we pick a Saturday. Another challenge, we know that Advantage plans, right? Most patients that have Medicare have a secondary. So we know that the Advantage plans are paying for RTM, the 20% that Medicare isn't, but we've had some challenges with the commercial secondaries. So not all commercial secondaries will cover this. And what I know so far is Champa, VA, Federal Blue Cross Blue Shield, and TRICARE are ones that we know don't pay. So again, highly recommend that you reach out to those commercial secondaries to find out whether they pay for that or not. Um, because now my next point is you have to decide how you're going to handle that. Are you going to pass that 20% that's not covered to the patient as a patient responsibility? That's what I do. But if you're going to do that, you have to make sure that you're transparent and that you educate the patient from the onset. If you're not going to do that, you need to also factor that into your math when you're looking at the cost of this or the ROI, the expenses, and then the reimbursement. So you make sure that you're making, financially responsible decisions. We know Medicare is great, but commercial plans such as Blue Cross Blue Shield and United Healthcare state that they pay for RTM nationwide. There are some states that are an exception, but again, I would encourage you to reach out to those the commercial policies to find out whether they pay for this or not before you would submit those codes. Another challenge has been delays in AR. So normally, I think the average is 26 days. You have a patient in here, you submit the codes today because you did your note within 24 hours, and then 25 days later, you get paid on average. Of course, there's always exceptions and delays, but if you think about this, the month has to go by. Then you submit the code. So 30 days potentially goes by. You then submit the code on the first Saturday, so another 7 days potentially. And then you're waiting another 25 to 30 days to get reimbursed. So there's going to be a longer period of time for your AR for RTM codes. So you want to know that ahead of time so that when you're looking at your AR reports that you're not confused and frustrated. I separate my AR reports so that it doesn't contaminate my clinical processes, and I can look at those separately. A big one we've mentioned a couple times, but recognize that the data service, right? There is no data service. It's an entire month, but your EMR and your insurance company requires a data service to submit. So now think about that. If you're the patient and you were discharged in the middle of the month and the end of the month happens, we submit the codes, you get an EOB, let's say 30 days later, which is now what, 45 or 50 days since you've been in the clinic. Immediately you're going to think, wait a minute, I got to call this physical therapy clinic because I was not there on this date. Well, of course they weren't there on this date, right? So you need to be prepared for those conversations that your biller most likely is going to have with them saying, well, you weren't here on this date. You're right. You're not being scammed. This is why, we have to put this in here, and this is why, and explaining it to them not only on the front end of care, but also on the back end of care when they call, inevitably with those questions, because it looks weird, right? There's nothing we can do about that right now because the health insurance companies have not adapted their EOBs yet to support these codes. And then my final, challenge or suggestion that I've seen would be there are times when insurance companies ask for supporting documentation. What are they looking for? They're looking for the signed plan of care that states you're going to do RTM, why, the justification, the frequency and duration, right? So simply submitting that is going to be what they're looking for. Don't freak out about that, but it is definitely something that's going to be asked for occasionally. We've had it happen 2 or 3 times. So hopefully this kind of gives you a little bit of a navigational opportunity as you're looking at some of the challenges with submitting the RTM CPT codes.